And also thank you to the fellow medical and allied health staff who are here with me tonight, Tim and Courtney and Roby and Vanessa, who are going to be taking you through the skills stations at the end of the brief presentation, which is really only going to introduce the topics that we're wanting to talk about. And then it's really about you practicing the things and asking any questions you can possibly think of. There may not be another chance to ask, in a way like this. So my name's Christian Tenfield. I'm a surgeon in Melbourne, but have also done a lot of retrieval work with the Army and a lot of work in remote islands up through where you're going to be sailing, often as the Army surgeon. And so I know what the facilities are like, and we'll talk about those a little bit later, and also what the conditions are like that you guys are going to be sailing through. On one of our stations tonight, we're going to be talking about the day-to-day medical kit that you guys will use for headaches, for stub toes, things like that. And then we'll be talking about your Cat 1 kit and the reason why the Cat 1 kit has changed a little bit, hopefully for the better, to make you guys safer, especially if you need it. The problem with the whole medical setup, and many of you guys might be rolling your eyes and thinking, oh, no, I'm not going to need this. I'm a great sailor. I don't need this stuff. It's like income protection insurance, like house insurance. You don't need it. You're sick of paying the money for it each month. But when you do need it, you guys are out there quite possibly for several hours or even a day or two before you can get medical assistance. We're hoping to set you guys up with the skills to be able to look after yourselves with the assistance of us over the phone. And we'll talk about Starlink and internet a little bit later as well as possible, so that you are in a really good position to keep going with the race. We'll talk about the S4 and the S8 drugs. Essentially, S4 drugs or Schedule 4 drugs are those drugs that you need a script for. You need a doctor to write the script. I actually, because I couldn't find my old one, I went and got some pen train today. I took my own script and they said you can't prescribe for yourself. So I had to get another surgeon to prescribe for me to get one of these so that I can show you, which I'll show you in a little bit. And then the S8 drugs, the Schedule 8 drugs are those drugs of dependence, which we will have for you for if you are severely injured or severely ill. There are problems going from Australia to other countries, including Japan, with those Schedule 8 drugs. So they will need to be locked up. They'll be very strict and very serious about it when you get to Japan. You won't be able to use them in Japan, even if you injure yourself in Japan. You will need to see a doctor in Japan. Everything will be locked up. Then you'll have access to them again when you leave. That's all fairly simple. But one of the stations is going to go through all of that in a lot of detail, including all of this stuff, the various laws. I was under the impression that I could just say, Cyrus, my mate, I'm just going to prescribe you all of these things if you need it. And Rosie kind of yelled at me, well, you didn't yell, but she was unhappy with that idea because it's not the law. It's against the law. It needs to be prescribed for the ship. And then all of those drugs outside of your basic medical kit will only be accessed by you through an authority from us. Okay, it will be a little bit like it is with the Royal Flying Doctors Service and the ranches or the cattle stations up in the top end, where the doctor will say, this is the drug I want you to take, this is the dose, and this is how often, okay, rather than you just going in and taking them, okay? And that's the way we're able to have these quite strong drugs on board for you to use. Yes. The trip back's a little bit different. We'll talk about the trip back because we haven't quite worked that out, because some people are going to be spending a very long period on the way back. So it'll probably be local assets that you'll be talking to about using those drugs. But we'll have a talk about it after. I haven't got in my head yet exactly what we're going to do yet for that. AMSA provides a service where it's essentially a rescue service, and short of a rescue service, they would prefer that you had other doctors, as part of the organising committee helping with that. So we'll have a talk about that after as well. I'll just get through as much of this as I can, and then we can talk, because we could spend a lot of time on this. So there will be doctors on call from the moment you guys start until you all get there, and then we'll talk about the trip home after we've discussed it as an organising committee, but it may be left to answer in this situation. And those strong drugs will only be accessed happened to the doctor through the race director, and also your documents, you know, exactly what you've given at what time, because if there is a complication, if there is a bad outcome, then we all are in, not all of you, but whoever's on the boat and myself and the race committee, you know, are going to be investigated in quite a lot of detail to see exactly what's gone wrong. No special documents, but we will have documents that.
There is medical incident. Okay. But we will come around and visit your boat, look at where you've got your drugs, and we'll bring those forms around so you know what they are. We ask you to keep them on the boat so that you can write down the information, you know, at home and relay or send us a picture of the notes, and then we can get back in touch.
Thank you, Rosie. And Rosie's the expert with this type of stuff, and she's going to be going over this with you on one of the stations this evening. Now, I ski with one of these green whistles. Okay, you don't have to be doing stupid stuff though to need this. When we got into Geelong last year for the Festival of Sail, one of our crewmen rolled his ankle coming down the stairs, and it bruised up very quickly. I actually thought he'd broken it. It was just a very bad sprain, and you know, he was at the point where he almost needed this. This green whistle, has anyone heard of or seen the green whistle? Has anyone not seen it? No? Okay, good. So, we'll, not sure. Okay. We will go through it in one of the stations, but essentially what you do is you take it out of the packaging. Let's do it in real time just to see how long it takes. So I got this prescribed today. There's documentation and stuff that you won't need. It's actually not supposed to be that good. So you take the plastic off, which you won't do. I won't do it at the moment. You crack it with that, open it up, you pour it in, swirl it around for about 15 seconds, and then you get the patient. George, just for a sec, you get the patient to just have a couple of very small breaths in first. It's got a funny taste, it's got a funny smell. It's going to make you cough if you take a very big breath, which we will get you doing as soon as you've gotten used to it after a couple of breaths. There is, and we'll show you on the station when you get to it, there is a charcoal filter here. And the charcoal filter usually gets thrown out by everyone, including the ambulance officers. It's only for the ambulance officers. Essentially, what it's doing is, as I take a breath in, what I'm supposed to do is, if I'm in a confined little space like an ambulance where they're seeing these whistles being used on a daily basis, every single day, you're supposed to exhale through the charcoal so that gas doesn't go into the cockpit. Okay? For our situation, it doesn't matter. Okay? You can almost give an anaesthetic with this. This used to be, and if anyone had an operation in the 70s or the 60s or the kind of 70s up until the late 70s, this used to be an anaesthetic agent that the anaesthetists used to put you to sleep with. The only problem with it was that it caused damage to the kidneys in high doses, which you often get with prolonged anaesthetics, and that's why it got taken off the market. Australia brought it back onto the market as an analgesic, and it's been used in Australia and New Zealand for probably the last 15 years or so. It's used by Bondi Rescue, it's used by Ski Patrol, it's used by the military, it's used by just about every kind of first aid responder because it's quick. You can get good analgesia with this much quicker than you can with morphine, with anti-inflammatories, with any of the others. Yes, there's 3 mils in that little bottle. Pour it into the end and swirl it around, and there's essentially like a fluffy cotton pad in there that absorbs the fluid, and then you breathe it in and out. You can either breathe it in and then have a couple of other breaths, depending on how much pain you've got. If you've got a lot of pain, you're essentially just breathing on it. And if you've got a lot of pain, you cover the little hole that entrains air in so that you're only drawing this in. And the analgesia that you will get from this is sufficient that if you keep on going like this, and this is what this is on for, so that when you kind of fall asleep a little bit, you don't drop it. You know, putting a shoulder in or something is quite easy with this. We'll talk quickly about shoulders whilst we've got it. Have you had your shoulder dislocated?
Yeah.
Did you try the green whistle?
Yeah, they gave me one. They put it back.
Afterwards? Or you tried it to begin with?
Just as I was in the active without it. And then
Yes. Yes, yeah. Can I borrow you just for a second? So let's imagine, and it's not a far reach, you know, a dislocated shoulder, even though you guys have been sailing for so long, is not an unrealistic injury to have, okay? Especially with only 2 of you on the boat. So essentially, the shoulder has popped out. So what's the best way to dislocate someone's shoulder if you want to? Essentially, it's this position here, and if I push just a little bit, I'll quite easily dislocate the shoulder now, okay? And so what we want to do is basically the opposite. We want to get you breathing. We want you kind of lying like that. Okay, I've been talking on this, so don't actually, but it goes around his wrist. And then essentially the reason the shoulder doesn't want to go back in is because of the spasm of the pec major muscle here. And so this muscle here needs to be relaxed. Okay, needs to be breathing on this. So coaching through a couple of slow breaths first to get used to it so you're not coughing and spluttering. Then breathing it in quite hard. All of a sudden, he says the pain goes from a 9 down to a 3. Start giggling a little bit. And then what we do is we gradually just start kind of massaging the muscle a little bit of what's called internal rotation, where we kind of pull the arm in a little bit like this, and then using your thumb at the back, flicking it back into space. Okay. We can use 2 of these a day. Okay, so essentially, let's imagine that Tim, who's feeling clumsy for whatever reason today, has fallen over and he's actually dislocated his hip. He's done it before. He's got a prosthetic hip. Sometimes it does dislocate. He's in a really awkward spot on the deck. This will probably last half an hour if he uses it continuously to get really good analgesia. Okay, in which case we've got the hip in. Get a second one, just fill it up again, and we should only use 2 in a 24-hour period to get him down below and kind of, you know, on one of the beds and go from there. Okay. Good. Any questions about Pentrain?
Yes, there's 2 listed.
Yes.
On, the medical checklist.
Yep. So 1 each.
So you've got 1 each. So you've got 1 opportunity.
Yeah.
Is there any problem using that in conjunction with other?
No, and we'll talk about that as well when we're talking about drugs. But no, there's definitely not. This is, if you think this as the quickest way you can possibly get really good analgesia, so that something can be, so that you can actually be moved into a safe position, and then we have the stronger medications. They're not stronger than this, but they're analgesia alone, as opposed to kind of a dissociative, which this is a little bit. Because often people will have this and they'll say, oh shit, it really hurts, but I kind of don't care. And that's all you want. It doesn't matter whether you've got pain, it's whether the pain is actually bothering you. If it's not bothering you, then this has done its job. Yeah, go.
Can we use this without making contact with?
Yes, you can. So we're going to kind of have it so that, because if there's an injury, you need to call the race director. Race director needs to call me or someone else. We need to get back to you. Well, that's valuable time that you know you should be using this and getting comfortable, getting the joint back in. The longer a shoulder has been out, the harder it is to get back in. And if that shoulder isn't back in within about 3 or 4 hours, you start damaging the cartilage, which means that you've then got arthritis for the rest of your life.
That's pretty much. I was going to say, like, the quicker the better, like keeping up with all kind of thing.
Exactly. Yes. Yeah. The quicker the better. So essentially, what I would do with these, I would have not his and hers, or his and his. It's 2025, isn't it? You have 1 upstairs and 1 below. Okay. And if you have an injury down below, you grab it and start using it. If it's upstairs, you grab it and start using it. And
If there's temporary, I'm assuming that's temporary pills.
there is a chance, and what we'll talk about this as a group later, but there is a chance that you will have an injury that will be trip ending. Okay. There are also quite a few injuries that will require you to have this that will allow you to keep going. I know how much you guys have put into this, and I want you guys all to finish. There will be a couple of injuries, you break your neck and you finish. Okay. But we're going to do everything we absolutely can to get you finished. I was speaking to one of my micro paramedic mates yesterday, and I was saying, this is like the Mount Everest for these guys. And he said, yeah, but a lot of people have to turn around on Mount Everest, and that is part of the process. Well, I want you guys to get there, part of the process or not. We're going to do everything we can to get you there. Okay, but we want to get you there safely. So this stuff here, they're only now really trialing. The last couple of years they've been trialing in the UK and America. They're a bit slow to have a drug introduced that has been proven to cause kidney damage in very high doses. The doses of this are thousands of percent of what it was that was causing issues. Okay, even to the point where the micro paramedics or the paramedics are all told, just get rid of the charcoal filter because it's not necessary. Okay. No, so this is the one benefit of this is it doesn't really depress consciousness, which many of the other drugs do. Okay, and the problem with that is if you've got a fully crewed boat, you can have 1 or 2 people assigned to making sure that you've got an airway and everything else. Now, of course, you're not in that position to do so. Morphine. I actually had a kidney stone last year, 2 years ago, and it was fucking horrible. It was the worst pain I've ever had. They gave me 15 milligrams of morphine, and I just said, I need more. Now, they gave me 15 milligrams now, I'd be asleep for quite a while. And if I was laid in a back position, then I'd probably suffocate and die. One of the worst rescues of all time was the Russians in Chechnya in the cinema about 15 years ago. I'm not sure if you remember it. And they filled the gas of the cinema with, or the theatre with anesthetic gas, and they pulled them all out. They got everyone out, and they laid them all on their back, and they all died. Okay, because they didn't protect their airway. Morphine is a terrible drug for having such a narrow little window between having good pain relief and knocking you out to the point where you need someone constantly there holding them. This has got a brilliant therapeutic index, which means that difference between giving you your analgesia and kind of, essentially, you can't have too much of this. Because what's going to happen as soon as you drop it, the next couple of breaths, you're there again. Okay, does that make sense with that one? You had a question?
We should finish up with 12 doses.
10 doses.
Yeah, 1 week. Yes. Yes. Yeah. Okay. And realistically, you can't kind of buy 1 pack. So we bought a 10 pack between 2 people. Even though it's a little bit, you're going to come back with some. Hopefully, come back with all of them. But it's the cheapest way for you to have it done. Okay, so this stuff is really safe. It's called Pentrain, Penthrox, methoxyfluorine. There's a number of different names from it. If people ask, but everyone knows it as the green whistle. People know it as, the Australian invention, because it is Australian. They've got a test in the UK at the moment. They're loving it in the UK. They've got a test in the UK because at the moment they're not giving it to anyone under 18. So they've got a test or a big study called the Magpie study, trying to see if it's safe. They can see all of our data, but they want to kind of do that data themselves. It is much better, it is much quicker, and it's a hell of a lot cheaper than laughing gas or nitric oxide, which you may have had. The dentist is coming soon. He uses that all the time. Really expensive to fill. Very bad for the environment. This stuff is much better. And to date, there's been over 8 million uses of it in Australia, or 8 million administrations with almost no side effects and no serious side effects. The one thing that we do need to be careful of, and we're going to send an email to every single one of you, is that if you have, and none of you will have this, that if you have a history of something called malignant hypothermia, or if there's a family history of malignant hypothermia, then you can't have it. And we'll have to come up with a different
given a particular type of anaesthetic, and this falls in the same category, that you start cooking and you get up to a temperature of about 42 and you die quite quickly from it. Okay, so that's a really important contraindication, but the only contraindication to the point where the AMBO don't even ask for it because they're going to a hospital where they can get the antidote. We don't have the antidote. Okay, and yeah, that's easy. Okay, so it is self-administered, really rapid onset. It says here 4 minutes, but you can do it in about 1 minute. You can get that really good relief in 1 minute. Just remember, if you do need to take it, not to take a huge breath in the first 1 or 2, just a couple of, get used to it, and then you can start in training really big breaths. Okay, it will last for approximately 1 hour if you're just using it kind of every now and then. But if you have to have something like a joint reduced, you know, an ankle that's kind of in a funny position to get you down below, you can kind of go a lot harder on it. So Luch's wasn't this bad, but you know, this is a really bad ankle, and you all say to yourself, oh, this guy's an idiot, I know how to sail, but you come down the stairs and it's slippery, it's dark, you know, it's not unrealistic that you could have an injury like this. To tell you the truth, this is a trip-ending injury if you get something like this. Sprain is not. I'm not sure if you guys can kind of see that, but that's a really bad ankle fracture. And something like that, or something like this. Luckily, we've got no old people in the group, but this is a fractured neck of femur.
That's very
and you can see that this here is shortened and externally rotated, okay, which a neck of femur often does. They're using this a lot in kind of nursing homes to get them into or onto the trolley, okay, with much better safety profile than morphine and the other stuff. Seasickness. The one thing I want to say about seasickness is that whatever, even if you don't have seasickness, when you normally sail, there is a potential of getting seasickness through being tired, dehydrated for prolonged periods of time. Whatever you're going to take, and I'd probably recommend the scopolamine patches that go behind your ear, is to take them on land well and truly before you go, as in, you know, this weekend. You know, the scopolamine patches last for 3 days. Unfortunately, you can't buy them in Australia, and the reason you can't buy them in Australia is because the number of people who are needing to use it are so small that it's not worth the company paying for the huge expenses to get it approved through the TGA, through the Australian system.
It is actually available for county funds. You can get it, but it's
okay. I've always been taught kind of that compounding pharmacies.
It won't be stable enough, but to try.
Yeah, I wouldn't use it. Yes, yeah. But certainly it's easy to get from New Zealand. It is easy. Richard, did you get it from New Zealand? Or was it someone else?
I've got it.
You've got it from New Zealand. Okay, yeah. And can you quickly say how difficult or easy that was?
Not particularly difficult. Basically, get onto Google, type in scopolamine patch, New Zealand pharmacy, and you'll come up with a couple of pharmacies around there. He has them in a commercial form. Usually a packet of 60. I can't remember how much it costs to mine in $70 as well, so not cheap things, but worthwhile. So that now they sent it to you within about a week. So there's a bit of time to involve. The other thing about being on the boat is I think it's really important to try the dose before you actually get it right.
Yeah.
There's the occasional person who doesn't like it, and there's the occasional person who actually makes you take it in because they get it psychotic.
Yeah.
Now that's really uncommon, but you don't want someone psychotic on the boat who's trying to jump off the side of the boat.
Yeah.
So that's one thing you should try beforehand. Try it beforehand so you don't get psychotic. Try it so you know if you're going to get dry mouth, which is like that they actually, you know it's coming. You try that before. And the other thing is it needs to be in your system for a while before it starts working. And if you just take it as soon as you get up surface, it's going to take another 2 or 6 hours before it continues. So you really want to take it, well, most people you should probably take it 0 hours before you get it. The other thing is if you are going to change it, it's just a 3-day patch. So you've got to take the patch off and put another one on.
Understand.
Well, yeah, but in particular, you want to do it with what's on. Because if you do it with just ordinary hands, you might get some of the blood on your fingers, and then you see wiping your faces, you don't mean you've got some of that blood in your eyes, and it can make that eye for people. You're shrinking, you can't see anything. So,
Really, really, really important. You either wash your hands incredibly well or you wear a glove to put it on. Okay. And the psychosis is a real issue. It's much more an issue with the oral tablet rather than the patch. Can still occur with the patch. This is why it's important to try it. And also, if you know that your fellow competitor has got one of these on because of seasickness, then you need to monitor behaviour and you need to have an agreement. Listen, I've been monitoring your behaviour. It's off. I need you to take the patch off, and you just have to put up the seasickness. Okay. But again,
2 hours for that, whatever side effect you've got. Even when you take the patch off, that side effect just some hours with your changes.
Yeah. Thanks, Tim. All of the seasickness tablets or medications, as Tim said, take several hours to work. They work through stopping you from getting it. Once you've got it, you're stuffed, and you've just got to ride it out. Having said that, nearly all of the naval cadets, when they hop on the ship, get seasickness for the first 2 or 3 days. After a week, none of them are seasick. Okay, so it is a habituation thing, and you do get over it. But during that period while you are seasick, you've got to make sure that you keep your fluids up because we don't want you getting dehydrated. This is some of the stuff that I do a lot of that you guys probably don't see very often, just every now and then, but I want all of you to have a really good go doing it tonight.
I just have a seasick question.
Yes.
Stupid.
Yeah, no.
If you're like on the medication and you've been on the boat for a week,
Yes.
you take it off, you start getting seasickness, or your body kind of adjusts?
Your body does get used to it, even if you've got the patch on. Okay. Now, the reason it goes behind your ear here is because what it's doing is it's essentially acting on your inner ear, and it's that imbalance between your inner ear that kind of tells your body where you are in position, and your eyes, which are lying to you. Okay, and that's why when you're up on deck and you're focusing on something on the horizon, you can kind of abate that a little bit. But when you're down below, with your head down cooking, it's a lot more difficult, and it can get really bad.
If anyone is having or has had a history of seasickness, to come have a chat because we actually have a lot more information about that. I used to work on a cruise ship where pretty much my job was to manage seasickness. So if you are concerned at all at any time, and as Tim said, I've looked after people with polyamine psychosis who've been trying to be homicidal for 12 hours post the patch coming off. So just be really mindful if you are trying it, you try it at home. Yeah, where there's people around who know what you've actually done. So
And Vanessa's going to be on the station talking about it tonight. So that, yeah.
Is that the only seasickness drug that causes that psychosis? Or?
that is.
Yes. And there's a lot of drugs that can do this. Malaria, the army kind of has doxycycline, which most people take because it's so benign. But mefloquine can make you homicidal. And when you've got, unless you're in the face. So so there's a number of drugs that can have funny side effect profiles, and it won't be everyone. It will only be every now and then that someone will get one of these unusual side effects. And so it's so important to take it now. Waste the weekend, and you're not going to waste the weekend, but try it this weekend. I guess if you get psychotic, you will. Okay, so suturing, stapling. We're going to show you some techniques tonight. I really expect that regardless of how good you are tonight, that if you do have a wound that needs to be sutured, that you talk to me or someone else when it's required, so they can take you through it, take you through some of the tips. We're going to show you some really simple little wounds. You may have as well. I spoke to Pip Hare recently when she was in Melbourne, and I looked through her med kit and I said, "Oh, you don't have a staple?" And she said, "Oh, no, they don't like staples because they're difficult to take out." And I said, "Well, when you're solo sailing, how are you going to stitch your arm?" She said, "I just use my teeth." And I couldn't believe that she'd been told by a doctor that your mouth is much dirtier than your anus is. It's got many more bugs, and dragging, your saliva through the wound just is crazy. So we've got, fortunately there's two of you, and so one person can suture the other one, and then you can take it in turns. But I'll show you the staples as well. Okay. Hopefully you're not going to need this at all. But if you do, a lot of the suturing that we're going to ask you to do is pretty simple. Okay. And it's once you've done it a couple of times tonight, you'll be comfortable enough with someone else guiding you through it, how to do it. Okay. Essentially what we're looking for is direct pressure, elevation, immobilization, especially if there's a fracture or a dislocation, splinting. We're talking about suturing, and tourniquet. I'm a little bit reluctant to talk about tourniquet, and the reason for that is because there's so many disadvantages of a tourniquet. And essentially that disadvantage is, unless you're within 2 hours of a big hospital, once that tourniquet goes on, anything below that comes off when you get deported, okay, or when you're rescued. I would much, much, much prefer that we are putting direct pressure on and not rendering the rest of that limb ischemic or lacking of blood supply. Okay, so we can talk about tourniquets at the stations. Happy for you to carry one. If you were out swimming and your bottom of your leg got taken off by a shark, then of course you put the tourniquet just above where the injury has been, knowing that below that's gone. Realistically, probably is anyway. But if you were to have the mast fall and something stabbed into your thigh here, I'd be very reluctant for you to put a high tourniquet on, because when those patients come into the hospital, we often say, but not often enough, we need to look at life before limb. Sometimes we do, or sometimes people do, concentrate so much on the limb that the patient ends up dying from having the tourniquet on, and then having all of that cold blood that's full of potassium and other metabolites coming back and stopping the heart. Okay, so don't want to make it scary, but tourniquets, everyone will say, "Oh, you should definitely have a tourniquet." I don't think so, but we can talk about it. So skin wounds are pretty common on boats. If deep and gaping edges need to be brought together, we have different layers of our skin. We've got a superficial dead layer. Then we've got the living layer below that, and it's like a conveyor belt or an escalator that comes up. On our lip, we've got the dead skin on the outside, and then as soon as we go over a little bit further, it's mucosa, which is very different. Instead of having a waterproof barrier, we've actually got a permeable barrier that allows kind of fluids to go in and out, because there, to the inside of our bottom, is all the same. It's all of this mucosa. But this dead skin area, the reason I labour it is because what we don't want, I'll show you when we do the suturing. Let's imagine that my nails are the dead skin, which they are. They're essentially just a form of that dead skin. If the edges want to roll over a little bit like this, we've got dead skin against dead skin, and the wound isn't going to heal. Instead, what we want is we want the dermis, or the live tissue underneath, to be kissing like this. And I'll show you a couple of stitches, even if you just do one of them in the middle, that encourages it to invert like this, as opposed to inverting, and then the stitches come out after a week or 10 days and the wound falls apart. Okay, so we'll go through that. So wounds that shouldn't be closed, that will be a case-by-case basis when we kind of talk over the phone. On the boat, you're not going to have these dirty, contaminated wounds, so most of them will be able to be healed. And, there's going to be no reason that the wound's going to be open for 12 or 18 hours before you get in touch with them, and we kind of work out what we're going to do. Yes.
I know a big case by case, but say we closed up all the wound,
yes,
and we spoke to you like, "Oh, that's no good. Open it again without."
Oh, definitely. Yeah, just cut the stitches out and start again. Yeah. But I'd really like to think that we can kind of go through it together. We are going to have an on-call system but it essentially means if you stub your toe, don't wake everyone up at 3 in the morning. But if it's urgent, if you would go to a hospital, if you'd even want to go to the doctor at home in the middle of the night, you call the race director, wake him up. He wakes me up. I talk to you until we get it all sorted. It's not your toe. It can wait until the morning, but nearly everything, if you're concerned, if you would want to see a doctor in Australia, the phone call happens. Okay. Don't try and battle with it yourself. Oh, it's only a shoulder, you taught me how to push it back in, and it's, a lot of bad things can happen trying to reduce the shoulder. So we want to do it step by step. Most of you will have Starlink, I presume. Will anyone not have internet? No. Many of the groups will. We can do a lot just voice to voice. Of course, the video is a little bit easier. We can get through more information, but if you're articulate with your questions, and we'll be able to get through. Number of different ways of closing wounds. The stapler, which is what the orthopedic surgeons use because they're lazy. Really, it is. There's no need for surgeons to be using staples, but they nearly always do. Many of the little wounds, especially on the face, you should be able to get by with the strips. Okay, the skin needs to be dry, needs to be clean, needs to be washed out, but then you should be able to put them together. I generally don't like glue, and the reason I don't like glue is because it's so tempting for people to fill the hole with the glue, which you don't want. You want to put the skin together and then put the glue over the top. Your fingers stick to it. It is quite awkward, and it's nowhere near as durable as having a stitch in. And you'll find the stitching fun. I think you'll quite like it, and especially if your teammate's pissing you off. It's going to be a great little experience where you're kind of helping them, but you kind of just, Okay, let's imagine that the wound is 1 centimetre deep. If the wound is 1 centimetre deep, let's imagine it's 5 millimetres deep. What we want to do is we want to take our first bite away from the wound edge, about 5 millimetres, go in 5 millimetres deep, come out to 5 millimetres, so that it wants to basically just bring that tissue back together. We don't want to bunch it up. We don't want to make it too tight. When you do go to throw your stitches, trying to make it too tight is actually not going to make it heal any faster. In fact, what it's going to do is it's going to deprive that little area of skin from some of its blood supply, okay, and it may actually become necrotic, then it will become infected, and so, we'll talk about this a lot when we're doing it, but it's this kind of seamless going in and out at the same length from the edge. If you don't, you're going to end up with puckered wounds, and when you finish this, if it looks good, it is good. If it looks kind of like a dog's breakfast, then it's, if you've got dermis up here, up against kind of the dead skin there, it is not going to heal very well. Okay, we're not talking about how it looks, we're talking about the healing phase and getting past the stage where you have to worry about getting infected. Burns. Hopefully you never get one of these on a boat, but they can be catastrophic. They can be boat ending, of course. The most common burn, and nearly everyone will probably at some stage get sunburnt. Sunburn is something that shouldn't be scoffed at. It can be incredibly serious. One of the staff members, Courtney, did you get burnt in Nepal?
Mm-hmm.
How bad was your burn in Nepal?
Horrible.
As in how bad?
It was really bad.
Did you go to the hospital?
I did.
Yeah, so some people need hospitalisation. It leads hand in hand with dehydration, which then ends to falls and everything else. It's really important to try as much as you can to avoid getting sunburn. To have some after sun stuff, so that if you do get sunburn at some stage, that you can help stop it from healing and turning into that vicious cycle. But the preparation of food in the galley, flares, of course. The immediate action is to kind of make sure that the fire's out. To take that source of whatever it is that's caused your burn, remove it, take it away. go through the ABCD, which we'll talk about a little bit when we've got the mannequin station here. Hopefully there won't be any inhalational burns. If there's soot in the nostrils, if there's any burns around the lips, it's probably going to be evacuation, because they're the ones that can quite quickly swell up the airway and stop you from breathing. So, you know, when you're away from Australia and too far away from Japan, you guys are just got to be so careful. The immediate treatment is running water, clean, fresh running water, for 15 or 20 minutes. Okay, there is a zone, there's a couple of zones. So there's an area of the burn where you will have dead tissue, and then there's an area around it where it's saying maybe I will become dead tissue, and you can stop that area from expanding by, you know, doing these first aid measures as quickly as possible. And we'll talk about glad wrap on one of the stations as well, because glad wrap for your situation is going to be such an important way of treating some of these burns. Dislocated shoulder, we've spoken a little bit about that. I spoke to an upper limb orthopedic surgeon on the weekend, and his thoughts were that realistically, this is a trip-ending injury if you were to get a dislocated shoulder. We're going to teach you how to strap the shoulder afterwards. Realistically, depending on how far from Japan you were when it occurred, you could still stay on the boat, but that arm is not going to be very functional at all, apart from doing small movements with your hand. You're certainly not going to be able to. Look, can I pick on you for a sec? After your shoulder dislocation that you had, how useful was that arm? It was your right, wasn't it?
It was. It was my dominant arm. I
Yep.
had 4 subluxations or dislocations in the span of 3 months.
Yep.
And every single time I did it, it was probably got a third more useless. And
Yep.
to the point where if I was just sitting and not engaging my shoulder muscles, you would noticeably see my shoulder just out of the socket. That was,
Yep.
that was not me.
And after you did your first dislocation,
Yeah.
what could you do and what couldn't you do with that right arm?
I struggled biking tables, opening doors, anything that was a quick reaching out motion where
Yeah.
there was any force twisting or going down my shoulder.
Did you use a winch?
Yeah, if I needed to, but I wouldn't have relied on me.
Yeah. And so these are the little discussions that you are going to have within your crew as to what injuries are going to be. Where's the line on various injuries where you're going to say, I actually have to come off the boat? Because, you know, again, we all want you to finish this race. It's going to be, you know, amazing for all of you. And we don't want you to come off, but there are going to be some injuries where you probably will need to come off. And I think a dislocated shoulder, especially early on in the race, I can't see you getting through the rest of the trip with that. But as a group, you need to talk about that. You know, once it's relocated, if we can get it relocated with the pen train, and that's our best possible way of doing it, then, you know, you are going to be comfortable. You know, we're going to have pain relief for you for the following days, which you'll need. You will be able to be a participant on the boat. You're just not going to be able to do much. Okay, and you just need to have those discussions. Yes. Rosie's my glad wrap may have come off the list.
The glad wrap is come off the list because you're going through a tropical area. There's going to be huge humidity.
Yep.
And the risk of if you're using glad wrap, and if you ever do use glad wrap, it always needs to be the strips with areas in between without for a dart. But the greatest problem is infection. And that's why we've got heavy duty in boats. So if you get a burn, you really need to get in touch with us quickly to work out when to and what sort of man.
Yeah.
That's what you do.
And being out on the boat, you better put the bucket over the side, the water's clean, and just put your arm in the bucket every day. And just wash out what's there that's dying off.
Yeah.
And then just allow it to dry out, and then put on the either silver or otherwise the solid side. Just keep tapping that on all the time.
If you're at the start or the end of the race, we might use some of the glad wrap from the kitchen. We'll talk
I
about it.
think we took it off the list.
Okay.
Can I ask a question?
Yeah, for sure.
Before you said, you know, like that 20-minute photo burn under running water.
Yeah.
We're on water rash.
Yeah, I know.
Yeah, put it around the button.
Yeah.
Yeah, I
Yeah.
to the counter.
Possibly raise the interest.
Stop order.
Can you use something?
You can, yeah. You just need something, you just need to try and stop that zone of necrosis from getting bigger. Okay, it actually physically stops the burning within those cells. There are some of those cells who are trying to decide which way they're going to, can they survive? And they can survive as long as they're protected as well as they possibly can be.
So ideally, cold water.
Ideally, running in cold water is going to be best, but we need to make compromises.
The water temperature will be about 132 degrees at the equator.
Yes,
So it's not a good time.
which would be useless as a, yes, yeah. Could you please click that aircon back on? I think it may have automatically, just behind you. Head injury. It's really sad that I'm having to put that up. But it's one of the realities of sailing. And it's one of the realities of sailing on a very long trip where you're going to get tired and you are not going to be as good, potentially, partway into the race as you were at the very start. At the very start, you are going to be, at your absolute best mental focus and physical capability, and then it may deteriorate a little bit, hopefully not too much, over time through dehydration, tiredness, sunburn, everything else. It is so vitally important that you protect yourselves from the boom and the main sheet as much as you possibly can. You guys all know that. If there is a head injury, we need to know about it. And that's one of the ones that we need to know about in the middle of the night. Okay. We are going to talk about not the Glasgow coma scale, which you probably all heard about, which many doctors still can't remember the 15 different components of it. And in reality, for what we're trying to do, what we're trying to convey with each other from the boats, the medical team, it doesn't matter. There's another system called the M2O score, which is whether the patient is alert, whether they respond to voice or open their eyes to voice, whether they open their eyes to pain, or whether they're unresponsive. Okay, and we need to work out very quickly whether a head injury is going to result in an immediate evacuation, because if there is a head injury with a bleed in the brain, we've got a certain number of hours. And the absolute horrible truth of this is that if this occurs in some of the stretches, that distance is probably going to be too long to get a helicopter in. Okay, in reality. And so there are passages that you guys are going to do where you just have to be even safer than you are for the rest of the trip, for fear of something like this. And one of the classic examples is someone gets hit by a cricket ball and they go down and they wake up and, they've been unconscious for, let's say, 30 seconds or 40 seconds. And all of a sudden they feel pretty good again. And they say, I'm just going to go and have a sleep. And then that's when that bleed in the brain gets bigger and bigger and bigger, and they often die whilst they're asleep, or they progressively get worse and worse. Okay, we're going to teach you some things like looking at the pupils and looking to see the size of the two pupils and whether one of them's getting bigger and progressively getting bigger over time. And I believe in the paperwork we have. Yes. Yeah. Okay. Yes. Yeah. Yeah. Yeah.
Just document it, get it to us.
Yeah.
And we can get that
Yeah.
to you.
Yeah.
ASAP.
Yeah. The other thing that's going to be difficult, and I keep on saying that I want you guys, and we all want you to make it to Osaka, there are going to be some times like after a head injury where it's going to be incredibly difficult for you and us to work out A, what's going on, and B, what to do. Because if we don't get you off the boat and one pupil is getting a little bit bigger than the other, and you have a very bad outcome, then it's going to be a very, very bad outcome. Okay. What we also don't want to do is for you to hit your head and have a little bit of a concussion and say you have to come off the boat. It is not going to be like that. You need to know that there is enough fidelity in the system that we're going to, as best as we possibly can, kind of draw that line. Okay. I spoke to a neurosurgeon this afternoon, who's one of my colleagues and who I operate with. We do a combined operation every couple of weeks, and we had a talk about this exact scenario. And when there is, or if there is a head injury, I will be speaking with him straight away and conveying every little part of the history and the examination that you're giving me. And so, you know, many of these drug choices that we've given, many of the things that we're talking about are not kind of just my ideas. This is kind of being taken from experts. So the drugs, the analgesic drugs, have come from about 5 different anaesthetists saying what they would have. The antibiotics coming from the best ID physician in Melbourne, so that we can give you 3 or 4 antibiotic choices that's going to cover the whole body, as opposed to needing 10 different antibiotics that increases cost, increases you know, the space that it takes up in your kit. Okay, so need to know that we want you to get to Japan. We want to do this for you as best as we possibly can and as cheapest as we can. We know that this is all expensive, especially when I talk about the AED in a couple of minutes. But also there are going to be times where, on the basis of what you're telling us, and we don't want you to hide things. We don't want you to say, oh, actually these pupils, they're not too bad, and one's really big and one's little, because you'll never forgive yourself if, you know, you do that, you know, to your colleague. Okay. And this does work. I went to Vanuatu for the earthquake just before Christmas, and on the morning of New Year's morning, I got woken up to a bashing on my door. You need to come and open someone's head. Okay, which is not something I do very often. I'm happy to do it. I don't do it often. And I went and assessed the patient. He was heard by the security guards at 4 a.m. screech, and then they found him on the side of the road. So they don't know whether he was hit or whether he was thrown out of the car. And one of these pupils was 2 millimeters bigger than the other. And I was like, oh shit. You know, this is going to either cause an international incident if there's a bad outcome. An Australian surgeon has operated on a local and it goes poorly because of a bad head injury and he was going to die anyway. And so it was a case of me speaking to this neurosurgeon. I actually spoke to 2 because I can get onto the first one straight away, and trying to make these very subtle little identifying facts that determine which path you go down. And it will be similar for you guys, whether we need to get you off the boat. This is a classic example. I mean, you don't need to be a doctor or a radiologist to see this. It's a projectile. It does. So this is looking at the head sideways. This is a CT scan. And that here's the chin, and this is the neck. And if you follow this line down, you can see that there's a huge step here. So this was one of my patients who was surfing, got dumped and hit his head on a sandbar, and he came out and he had a little bit of numbness in one of his little fingers. Okay. Most of the neurosurgeons that have seen this can't work out how he's not a quadriplegic, because he should be, because the spinal cord runs in here and it's come down through here, and it's done a right angle here and it's come down through here. And the only reason he's not a quad is because all of these back parts of the bone, what's called the posterior column, snapped as well, which gave this a little bit of laxity to go through like this. Now the issue with this, and the reason this is so scary, this CT scan, is that he had almost no symptoms. Okay, but he did have pain in his neck. And so this is not on the, and again, you can say, oh, Christian, this medical kit's getting bigger and bigger. The neurosurgeon I spoke to said he would absolutely definitely get one of these. I don't know how much they cost, but as you can see, I passed it around. It is not very heavy and it doesn't take up any room at all. This is in my car, so this is in my boot well, just where the spare wheel is. One of the things that we can do if you get a neck injury, okay, you have a bad fall, you get a neck injury, provided it's not an immediate, we need to get you off the boat, you put that on, 24 hours later, we get it off, we ask if you've got any neck pain, we feel the bones in the middle, the spinous processes here, okay, which are these things here. After 24 hours, in the absence of any tenderness of those, and you don't have a sore neck, we'll be able to get that off and keep you going. Okay, trying to do everything we possibly can to keep you guys on the boat. penicillin. Does anyone have a penicillin allergy? Is it a true penicillin allergy? Okay, there's a number of people who have an allergy to penicillin. What we're going to get you to do, we're going to find out everyone that's got a query penicillin allergy. We're going to get you to go to the doctor and have a test dose in front of the doctor, so that if you were to have an anaphylactic reaction or something, we then know that you're truly allergic to penicillin. Okay, and it's not a problem if you do have a reaction. There's lots of drugs that they can give you, and you're then fine. But what we don't want is to have penicillins on board the boat if one of you or both of you have a true allergy to penicillin. So most people, they have a query penicillin allergy, and it's actually not a penicillin allergy. Okay, so we'll get that organised over the next week or so, and you then know that you're actually not allergic to penicillin. Okay. Yes. Yeah. So we just need to know. So it's no problem if you don't think you've got a penicillin allergy, because by now everyone's had an antibiotic. Do you think you might be allergic? Oh, not sure. Okay. Yeah. Okay. We can have a chat about that after. But it's really important that you are not on a boat with a potential allergen that could cause you to have an anaphylactic reaction when you're away from hospital. And it's really easy. Just go to the doctor and say, I want a test dose of augmentin, and they will help you through that. Okay.
Most people that so-called allergies to penicillin actually got it back in the 60s and 70s when people got it shot in the bum. And in that shot that's put in the bum, there's all the preservatives and bits and pieces that are part of the medication. Whereas if you get a shot of penicillin, there's none of those preservatives. And so most people are actually allergic to the preservatives.
Okay, and the malignant hypothermia, we just need to know that no one's got a family history before taking the Pentrain, which otherwise will be a very, very good drug for you guys to have. Okay, this is not mandatory. Okay, but if I was, it's not mandatory because it's expensive. Okay, it's not mandatory because there are some crews who probably realistically don't need it. Okay, so I think anyone above 60, I would definitely take one of these. There is a new Australian one that's $599, which basically snaps in two. You peel it off the sticker back plate, put them on, and it reads it out and senses it. If you don't use it before it expires, they give you a new one. If you do use it, they give you a new one. Okay, and I realistically think that $600, I know you guys have spent a lot of money on this trip already, but when it comes down to it, $600 compared to what you have paid, this is your one lifeline if you were to have what's called an arrhythmia, which means that instead of your heart rate, like the Apple Watch does, instead of your heart rate being in sinus rhythm, it can get to a stage where it just says, oh, I don't know what to do here, and it kind of just goes into a really funny rhythm, which will usually come out from a really bad diarrheal illness associated with dehydration and potentially throwing off your electrolytes. Okay, what I am not going to suggest, or actually, can I get a volunteer? Sure. You've been volunteered. And Courtney, could you please monitor what we've got here? Is we've got a mannequin that has sensors in it that shows how good CPR is. And Grant, can I please have a 2-minute timer? And Cyrus, if you come over here, Cyrus, Courtney's going to, if you come around the other side, Courtney is going to quickly show you how to do CPR, even though you've done it in your course. And we're going to get you to do it for 2 minutes. So whilst he's doing that for the 2 minute, Grant, if you could please tell me. So these things, this is a training monitor, and it's a little bit old. It's smaller than this now. I've looked at the prices, and they're about $1,200 to $1,500. I realistically think that this is your one shot of restarting your heart if you were to need it. Again, you're not going to need it. It's going to come back at the other end, and you're going to say, well, it's kind of a waste of $200, let's say. Okay, let's go.
Yeah, I'll tell you.
Time out, start now. 2 minutes, please. Okay, so you're going to do this for 2 minutes. The reason he's doing this for 2 minutes, and the reason we're not teaching to do CPR on a regular basis, is because we'll be tired in a couple of minutes. One of the paramedics that I spoke to recently, they went to a scene. There was just two of them, two big guys. They were doing it for 7 minutes, 1 minute on, 1 minute off. They both had to go home at the end of that 7 minutes because they were so exhausted. Right, so keep going.
Keep going. You ready, go ahead.
So he's done 1 minute.
No, you're on that. 45 seconds.
Oh, 45 seconds, okay. So what I'm going to tell Cyrus is at the end of 2 minutes, we have been able to get in touch with the helicopter, and it's 6 hours away. Okay, there is no way that Cyrus or anyone else, regardless of what training they've had, are going to be able to do CPR for more than a couple of minutes effectively. Okay, and if you don't do it effectively, then you're not getting that blood up to your brain, to your heart, to your vital organs. So what I am suggesting, and I know that this sounds a little bit crazy to some people, unless you really think about the situation you guys are going into, if you do not do CPR, unless you have an AED that you put the paddles on and they say, start CPR. Shockable rhythm, stand away, shock. Start CPR for another minute if it hasn't done it, and it will do that 2 or 3 times and hopefully shock you back into a rhythm. But during that 2 or 3 minutes, that blood flow has gone through the vital organs of your body to keep you alive.
You're watching that.
Okay?
2 minutes is a long time. 2, 1.
How are you feeling?
Pretty tired.
So what I just told the other group is that the helicopter is coming in 6 hours away.
So now I'm working out if she'll fit in the fridge or not.
So does it make sense, the thought of not doing CPR? Okay, yeah,
It makes sense.
Yeah.
Like in reality, I'm going to be like, oh, fucking so can.
yeah.
Break your ribs.
Yeah.
See what happens.
Yeah. Oh yeah, the breaking the ribs isn't going to make any better, but you're right, to do this effectively, especially in kind of our older competitors, you are going to be breaking ribs. Okay, it's a fact of, you know, if you do it on children, you can run over a child in a car. You shouldn't, but you can, and there will be no fractured ribs. Okay, and so these poor little kids sometimes do get run over, they get reversed over. There's no fractured ribs because they are so elastic, and all of the internal organs have been squashed. The other end of the spectrum is the older patients can have multiple fractured ribs from not doing excessive or excessively hard CPR, but literally going down a third of the height of the chest, and that's what you do. You're not going to be able to do CPR effectively for hours. Okay, so when you're coming around, up towards Sydney, then of course you're going to be fine, and realistically you're not. But you try it, but certainly when you're several hours away from help, unfortunately the reality is that you're not going to get a good outcome. But for those that do have an AED, and I certainly wouldn't do the race without one, if it says to do CPR and to at least give you the best possible chance of getting the patient back from a rhythm disturbance, provided you do get a good rhythm back and they start breathing again and everything, then that's the time to do it. And we'll have a little practice of that. Does anyone have a question about the AED? Because it is a bit overwhelming to think about. It's a bit scary. It is, shit, I definitely get the $600 one. If you're thinking of, no, I can't afford to get that one, I don't want to get that one, get the $600 one.
So apart from like underlying heart disease and that sort of thing, what are the top 4 or 5 things that would be preconditions for needing to use the AED?
So
what's going to be the AED?
Yes, so if there is anyone that's had a heart attack already, if there's anyone that's got AF, which is atrial fibrillation or unstable, if there's anyone that's got a valve problem in their heart, if there's anyone that gets quite bad angina, these are all the things that we need the GP to kind of pick up. The GP should know this because they've been treating you, and they will say, I'm happy to sign this form after you've seen seen the cardiologist, because what we don't want is for one of you to have a serious medical illness out there with a very poor outcome.
So those are all, they're almost like things that have already occurred. I'm more interested in second or something like.
So someone young,
for example.
yes.
So an otherwise healthy person.
Yeah, otherwise healthy person, then what we're talking about is an electrolyte disturbance or imbalance. We've got sodium, potassium, magnesium, a number of really important trace elements that need to be kept within the cell and within the bloodstream at a certain level. And Tim's laughing, hearing a surgeon try to explain something like this, and he knows kind of much more about this. And they can get thrown out of balance through excessive sweating and then drinking copious amount. You're not eating because you're feeling sick, but you're able to drink water and potentially diluting those nutrients, those minerals, sorry.
It's quite expensive seating.
Yeah.
You have people who can end up every 12 hours.
Yes. Yes.
And overdrink water.
Yes. And diarrhea. Okay. So, you know, I'm not here to tell you how to wash your hands, but realistically, every time you go to the toilet, you've got to have, you know, one of the bottles of alcohol rubbed there to wash your hands. Every time you go into the kitchen, you know, you wash your hands first, because in Melbourne, it doesn't matter if you get diarrhea for 2 days, you know, it's an uncomfortable experience. Out there, it can lead to a fall. It can lead to dehydration and potentially, absolute worst case scenario, an arrhythmia that could require you to need to use this, and this is not 100%. Okay, hopefully, if you do have one of these and if you do need it, it will be effective. And this is the kind of thing that you do not wait for the telephone call. Okay, you get onto it straight away, and then, you know, if you can, you call midway through or whilst it's shocking, or you know, just to see what else we can kind of do about it.
The other thing is,
Yes.
if you do get diarrhea, please don't think, oh, it's just one of those bad food days. Think about, it could be something that someone's put on the boat, the other person's very much getting it. So there'll be a real problem for people who are that sick for a couple of days. So please ring us as soon as you've got it, even if you're okay, just so we can remind you about things to do, and taking some hydrolytes or Gatorade to keep your minerals in your blood levels up, to reduce the risk of you then going downhill. Don't wait until you're feeling pain, horrible. All this, that's what we're there for, is to prevent stuff and get you on the right track.
You may have heard the terms cardiac arrest and heart attack. Cardiac arrest is where you've got that abnormal electrical impulse that goes through your heart and gets that coordinated contractions of the heart, as opposed to a heart attack where one of the arteries that supplies the heart, and that's why you're doing the CPR, you know, as part of this, where that gets clogged, and you need a stent or a bypass or something similar. Okay, so these help with this, but they don't help with this. Okay, and hopefully, if you have a narrowing of one of the arteries in your heart, you will have had symptoms of that with angina. You will have spoken to your GP about it. You'll have had a stress test, because we want you to do all of those things before getting on the boat. It's not. Any questions before we go into, I think, the dental and then into the skill stations? Any questions at all? There is so much to cover in such a short period. There's so many things that could happen. I mean, there's things that can't happen, like a snake bite, unless you're swimming, and okay. But you could have a reaction to one of the Portuguese man o' wars, like Hip Hare had. So she actually got stung on the back when they were being washed up on the deck, and she lay down on one. Okay, so, you know, if you
might keep alerting, can we maybe have questions to the table? Just
yes,
we're getting it.
yes, yeah, of course, yeah.
Good evening, everyone. My name's Simon. I apologise about the delay. I've been in someone's mouth for 9 hours, and that was been a long day. I did a very quick PowerPoint about some of the very simple dental things I want everyone to think about before they go on their journey. Firstly, when I was asked to talk to everyone about this, I considered your group to be very similar to a lot of the courses I see for deployment. And I've noticed that Christian was talking about stress tests, about GPs, about checking for health and well-being before you go somewhere. These are all the things that armed forces personnel do. And we have to sign off on those things before they can actually go to work. Go ahead. So essentially, dental concerns are overseas. There was a paper done on this in the 30s, about 100 years ago, and they were talking about scurvy being the main one. I doubt anyone's going to get that. Dental loss overboard was a big one for a lot of people coming on liners and boats down under when they were immigrating. But all the way through that, trauma and infection. So these are two things that I want to cover briefly tonight. And certainly infections can be mitigated and even halted before they start. Trauma, hopefully you avoid things and don't get bashes to the face. So the New Zealand and Australian Armed Forces, they talk about medical fitness and dental fitness. For me, essentially, before anyone can be deployed, I need to fix any urgent dental issues. I need to have a chat to the client about making them aware of what's going on in their mouths, how they can hold things. I have to educate them. We have to have an OPG done, which is an X-ray that goes around the face, and that's for identification. And then I can sign off.
Sorry, some quick on the OPG. Is that a document or how you guys need to start this process?
For the ADF, it's
For the ADF.
yeah. Sorry, for you guys, I'm recommending you actually have one because A, unfortunately, it's for identification, and B, especially if you've been lost at sea for a while, and B, it will show up any problems quite easily, and most radiologists will bulk bill it. So it's a very useful X-ray that you can have referred by both the GP and the dentist. Okay. I normally recommend people do them every 18 to 24 months, depending on their needs. Certainly, if you've had lots of changes in your mouth since that one, those changes could be unknown. So yeah, if it's been a few years, please do. Facial and head trauma. There are over 70 muscles. All the sensory organs are here. We have the brain. We have, I think, 35 to 60 different types of bones. There's glands, there's arteries, there's blood vessels. It's a very compressed area. If there's an injury here, it can be quite complex. It can actually involve several types of situations. It can involve your airway. It can involve your gastroenteric tract. It can, if it's on the brain, bleeding, etc. So essentially, if you're a sports player and you had a traumatic incident on your field, which is your workplace, we would take you off. So if you have trauma on the boat to the head region, you need to consider concussion rules. Number one, don't keep saving them, please. And also, head trauma can be serious. People can actually faint, die, have bleeds, all sorts of things unknown through facial and head trauma. So it's something that, yes, we get traumatized in other parts of the body, but the head, neck region, quite complex. The interesting thing is, if you have lower facial trauma, which is mostly what I deal with, it can actually be a bit different to up here, and certainly a bit more manageable, ironically. So whilst messy and painful, some common sense can help you with some very simple things. Thank you. All right. Oh, thank you so much. Excellent. So if I go back, perfect. Okay, so the main structures that we deal with in the head neck region, the lower jaw. It's a bone on two hinges. It's like your hips, your shoulder, it's a ball and socket, but it's joined together. it can be easily dislocated, and people can walk in and they can't open their mouth, they can't move, and it's actually stuck. Very careful manipulation can get it back in, like the shoulder. You know, you see people pushing their shoulders back in, but you can also do some really serious damage. So it's something that I want you to be aware of, but certainly it's something that might need, right? And also they can actually go back to normality after a period of time, especially if it's a delocation or a disc or something, they can actually manipulate themselves. The upper jaw, which is more this part of the face, is a bit more complex. It involves the nose, it involves the cheekbones, sinuses, trauma here. If you were in Melbourne, you would go to A&E straight away. Cuts, lacerations, abrasions, they happen all the time, especially in the mouth, our lips, our tongue. And we also have foreign bodies that we have to be aware of as well that can get lodged into these tissues. The teeth, I'm going to quickly run over some of the things that we deal with. And certainly some I was thinking about if you were at sea in the middle of nowhere, some could be manageable, others I would want you to seek help. So, treat teeth trauma. We classify it into different ways based on what it harms. So if it's superficial, such as the LS1, it's fine. The more you get, the closer to the nerve you get. And I often describe teeth like fruit. They've got a hard outer layer, a pith, and then a soft innards. And if you get to the soft innards, you'll be in pain. So essentially, teeth are embedded in bone, and they have a ligament, they have blood vessels. So teeth pain, I also liken it to digits, so your fingers and your toes. If you stub a toe and it swells up and you touch it, it hurts like anything, just gentle pressure. Teeth are the same. So what do we recommend after tooth fracture? Well, we recommend to see if the tooth is sensitive. Is it sensitive to touch? Is it sensitive to temperature? The more it's sensitive, the more problematic that tooth is. If it's not sensitive, is it sharp? So over COVID, I couldn't treat my clients, so I was telling a lot of people to buy emery boards, and if they broke their teeth or their fillings, they were grasping their teeth like a horse. So if it's rough to the soft tissues, it can ulcerate you, and an ulcer, believe you me, in the mouth can last several weeks, and it can be quite annoying and quite debilitating. So if you have a chance of lacerating, take an emery board with you. Anti-inflammatories and paracetamol, they are both useful in the head neck region due to the fact that we're dealing with nerves from the brain and nerves from outside the brain. The anti-inflammatory action is really useful, especially for teeth, from ibuprofen, but paracetamol helps dull the pain receptors as well. So using both is really useful. Salt washes while you're surrounded by the ocean, you're fine. That's really good as a holistic homeopathic one.
So with salt washes,
yep.
Does it matter where you are in the ocean in terms of?
If it had the massive plastic area in the Southern Ocean, I wouldn't use it. But if it was reasonably fresh, I don't see an issue. I would just go how much pollutant is around there. If you want to make it up yourself, here's a teaspoon to a cup. Always be careful with hard, chewy, rough foods. Now, I did say to one of your colleagues about a dental kit, and I'm going to recommend some things to take with you. But two very simple things that you might want on board are some wax and some Teflon tape. They're quite useful for other things, but wax, and we have lots of waxes in dentistry. If you've got kids with orthodontics, you'll probably have had to buy some. And Teflon tape also is quite useful because it can be used in a wet environment. And we use them in the mouth in trauma. Emery board again, and also I'm going to recommend taking a high fluoride or a sensitive toothpaste. A, you'll have your own water supply, and B, if you have exposed tooth dentine or tooth surfaces, they're likely to sell to yourself, and they'll all be listed shortly. All right, trauma, the sort of trauma that I think you can keep safe. We have different types of classifications for knocks to teeth. I see a lot of those when on Monday mornings after the weekends, and the simplest one is concussion, a knock. The tooth is very sensitive, it's inflamed, it could die, but that will take a bit of time. The nerve, the blood vessel might be compromised, but it could be inflamed and come good. That only time will tell. So tooth trauma, concussive wise, it sort of gets a bash and a knock and it's feeling a bit comfortable. And that one there, essentially on the upper left, you would just use common sense, soft diet, take some anti-inflammatories, paracetamol, and monitor it. If you get these other three, one is what we call an extrusion, where it sort of pops out. In Melbourne, you'd go and see a dentist, you'd be numbed up and they might try and push it back into place. On the boat, I'm not recommending that. I'm just saying live with it and deal with the consequences when you come back. That also would have the same sort of symptoms and you deal with it in the same way. The upper right is what we call intrusion, where it's just been knocked right up. Hopefully, it's nowhere near the nasal spine or the central nerve here, or the palatine nerve, and also near the sinus where they can sort of push through. Those ones, if they're stable, again, there's nothing you can do about it. Take some pain relief, salt washes, soft diet, you'll be good. Now, my staff, when I put this one up, they were like, why on earth are you telling someone to keep sailing if they knock the tooth physically out onto the deck? And I'm like, well, on the sports field or in town, we'd say, carry it, put it in some milk, some saline, rush to the dentist, try and put it back in again if it's clean. Please don't. Just treat it like you've had a tooth out. And again, when we take teeth out, in fact, it's probably a lot cleaner this way because it's come out a bowls, what we call it. Salt water washes is what you'd be doing, and take some pain relief and maybe an antibiotic. So if you end up, as my staff say, Collingwood supporters, then essentially, unfortunately, just continue on. It's like you've been to the dentist for a tooth extraction. All right, so just to overview that, consider your options, and that really is based on how much pain you're in. Is it debilitating or can you push forward? Do not try to push a tooth back into position. Do not try to replace it because you can't guarantee you've got the foreign bodies off. You'll be introducing all sorts of Portuguese man or remnants in there. Pain relief, salt washes, soft diet, and then I did put down, if you want to be a MacGyver, and the young ones probably don't know who that is, a bit of wire and whatever non-toxic glue you've got, try and secure the wire across the teeth. I've seen that done in a farming town I live in, and they were quite keen on that. Teflon tape over any fractures, and also, have you all had your tetanus vaccinations up to date?
Recommendation is now that we have one up to 50.
Right. Yeah, but it's normally 15 years or 10 years depending on the type. So I just want to know if everyone knows their status.
We do ask for medical.
Good. And also, if you make sure you know your allergies. All right, if you've taken medications or things like that. Okay, these ones, if you're in Melbourne, you definitely be having urgent care because the pain would be unbearable. So what we have here is a root fracture, and also we have what we call a alveolar fracture, where the tooth has not just gone in or pushed, it's actually pushed outwards and your whole bone is broken. You'll know that is because you'll feel that and it won't be pleasant for you. So those ones, I would say you need to consider your options or have very good pain relief. These ones, unfortunately, I would suggest you go to Port now. I grew up in New Zealand, in North Auckland, and a lot of sailing people. I have seen trauma from sailing in my both career and also my youth. So please duck if anything comes at you. These ones here were done on the sporting field. Essentially, they're all things that would have instant hospitalization. So you've got, this is an OPG, by the way. So it's a very simple way of seeing information. And then the middle one's an ICAD, where it's a three-dimensional one that they have in facilities. And this poor gentleman, that's what he was looking like after that injury.
Keep your last slide on before this starts. The oil of clove be enough to numb the pain?
Okay.
Allow you.
Oil of clove works by it's like pinching yourself. It's sort of forcing it a different name to take your pain away. It's actually not. It's been used for several hundred years, along with mint and all sorts of other things in the mouth, and it's just carried on. Yeah, so all of clove, no. With cooking, yeah. Curry. Okay, trauma of the soft tissue invariably happens with trauma of the hard tissue. And this is where we talk about foreign bodies. So if you get an impact of your jaw here, now at night, you can actually put your lower lip between your teeth here. Best case scenario, the lip gets traumatized, but the teeth get saved. Two hard objects come together, break. Something soft in between, brilliant. Always put your lip in between. It will heal. So you can see that, you know, here someone's bitten through their tongue on those two slides and also traumatized their lip. It's messy, it's bloody, but you will recover from this. The only thing is the stemming the bleeding. Tongues and lips have some very big arteries, and you can bleed, and if you bleed in the mouth, you can actually damage the well. It can contribute to blocking your airway. So always be wary of that.
Pressure on, say,
Yep. Actually, I did put gauze up there as hopefully that's in your, you know, healthcare. But by the way, AED device, I actually have one in my car because I travel the country and everything. And we have one at work. The $600 ones, yeah, you can afford the minimum 1,000 ones. They're a bit better and multi-use. And to be honest, if someone's lying on the ground here in Melbourne, they literally could be a lifesaver. And on the boat, given that the average age here is probably 35, I would say that yeah, 35. I would say definitely if you can afford it, have one on the boat, please.
That's right. Thank you. I wasn't clear what you were suggesting about the oil of cloves. It's not on our list.
Oil of cloves has nothing to do with dental. I want to disparage you from. I haven't put it on the list myself, but if it's on the list, I don't know how long it's been on the list.
Probably 100 years.
Australian sailing have it on the list, and it's also in the New Zealand.
It's tasty. It's very tasty.
That's because it helps with the flow of land.
Well, it takes food off it.
That's the whole point. It's a distraction. It's not actually a therapy or something that will help you.
Won't do you any harm.
It won't do you any good either. Okay, so yes, the basic rule of thumb here is compress, immobilize, and I believe you're learning how to suture yourself soon. Ideal for these situations. I am going to, at the end, there's a couple of topical anesthetics I'm going to say you might want to take with you, because if having to suture yourself there, it's going to be a lot of fun. And the tongue muscle is a very thick muscle, and it takes a bit of pressure. The lip muscles here are quite mobile, they move all the time. And it's like, you know, you're suturing a pig that's running around, you know. So just understand that everything moves. All right, oral infections. This is what you can avoid. This is the main crux of tonight. So understand that the mouth is a cesspit. It has got millions of bacteria in it. Some of these are very good microbes. They actually help us. They help metabolize our food. They help, you know, give us some benefits. But there's a lot of bad ones in there as well. And what we have done is we've linked mouth health to the rest of the body finally after it being excluded for 200 years. And we know that bad oral health will give you heart disease. It will give you liver, kidney disease. It will lead to low weight in birth. It will contribute to hypertension, all sorts of things. It's not just the microbes, it's what they do to the body. They create metabolites, they create things in the immune system that cascade down the line. So healthy here, healthy everywhere else. Okay, infections can occur anywhere in this area. And the microbes will also grab onto anything artificial. So if you have a filling, a crown, an implant, a root canal, you've had dentistry, they are going to grab onto that. If you have a denture, and you don't put it in lovely bath every night, it'll be coated in microbes. All right, so how can we mitigate? Well, please, if you haven't seen a dentist, go and have a check, just one, so at least you know what's going on. Please be aware of your own personal dental health. Have you got a removable device? Do you have a snoring device? Do you have a mouth guard? Do you have crowns, implants, everything? You know, they all need different ways to look after themselves. Please practice good hygiene. All right. I lecture lots of people about, well, I coerce them, I should say, about good hygiene. So if you have a manual toothbrush, electric, they're different. They work in different ways. If you use floss, if you use a water floss, they're totally different. If you are a 12-year-old I'm telling to clean and he comes to me 4 years later going, I'm cleaning my teeth now, because he's kissing, and I told him years ago he wouldn't kiss until he brushed his teeth, that's a win-win for me. So just, this is good. Stress. I'm sure that when you're out there nautical miles from anywhere, it'll be hairy and stressful at times. Stress is directly linked to a lot of dental issues. Something as simple as clenching. So if you're a bit of a clencher, and there can be whole families genetically who clench, or it can be brought on by stress, you can break teeth, all right, or cause pain. If you have a predisposition to gum disease or cold sores or ulcers, stress will bring them on. Okay, all these structures get infected. So teeth, I'll be covering wisdom teeth. I didn't put anything on dental implants. Does anyone have one? Dental implant? Okay, cool. Gums, saliva glands can get infected and blocked, and this often presents as a big swelling. Often that'll pass. Sinuses, I'm sure you're all aware if you've had sinusitis or infection up there, and it can be quite debilitating. The palate, tongue, cheeks, lips, quite popular. Now, the pterygoid mandibular space is a very fancy way of saying this rather unique space between muscles and bone that has a couple of very important arteries, veins, and nerves at the back of the mouth. Dentists inject it all the time to numb up the jaw. That is where infections spread from the mouth, especially around the wisdom tooth area. Once it hits there, that is your lift shaft to the brain and down to the heart. So if an infection hits there and you don't have access to antibiotics, you're going to be in a bad way.
They do.
They do have anything? Excellent. Yeah. Good. So I'm recommending that. Okay. These are just the symptoms. This is what people present to me every day. So pain, throbbing, referred, pain on biting. Is it sensitive to hot or cold? Do they get swelling, bleeding, ulcers, discoloration, blah, 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 blah. So there's a lot of symptoms to oral conditions, and the guys can send you this as well. It's a PDF that we can have. All right, so tooth infection decay. That's the bread and butter of the dentist. It can be avoided. The decay is basically, again, like a piece of fruit. It's rotting down inwards to all the good things, and you have to excise it away and repair it. And unfortunately, it can be brought on by lots of things. It can be brought on by social habits. It can be sugars and diet and so forth. Bad hygiene, stress, medications. And if you guys are on some interesting medications while you're traveling, it will affect your saliva and all sorts of things that it can. And if you're not as hygienic, you can get decay over time. All right, tooth infections are avoidable. So abscesses are essentially where a tooth dies, and an abscess is where it's infected by microbes. A cyst is where it's sterile. They both present the same way. They both look the same in the mouth and on an X-ray. And they can occur in virginal teeth. They can occur in restored teeth. And they're just this huge void in the bone, which is a ball of pus, essentially. And that's what we remove. And it just gets bigger and bigger and bigger over time until it perforates something. Either comes out the front, the side, you know, whatever. And if it's the bloodstream, no good if you're a cardiologist. Acute gum infections, they come on pretty quickly. So I'm saying they're unavoidable. And this is what we call ulcerative gingivitis. It's gone through several names. It's now called, well, actually NUP, necrotizing ulcerative periodontitis. It's often a stress-related condition. It comes on like it becomes itchy. and then they start to liquefy. It stinks like crazy, and it's sort of the closest you get to scurvy. All right, but it's actually from stress, heavy smoking, working too hard, partying too hard. It's just not doing a good thing, and it just needs to be clean. But the gums have unfortunately rotted away permanently. The one thing we do see a lot is chronic gum infections, which could be avoidable if you saw your dentist had it clean and they were good and checked your gums. And this is where the bone gets eaten away and you basically get long in the tooth. So some of you in this room right now could have some periodontitis. It's probably going to be fine, but eventually it's going to blow up in your face, literally. Wisdom teeth infections. Who has wisdom teeth? Anyone? Excellent. It doesn't matter how young, mature, whatever, as long as they're clean, not infected, no gum disease, you can have them as long as you like. That's always been my policy. If, like on the right-hand side, they're infected or decayed, I personally, if that was one of you, I would not let you travel because that infection theoretically could spread back to that special space and cause lots of problems. They tend to happen pretty quickly. Something gets stuck around them, or and they get infected, and you soon know about it because you can't open your mouth. It's one of the signs is you can't open, it's swollen, you get difficulty swallowing because it's going back into that space and it's impacting your airway.
So when they have the dental check next week,
Oh, okay, having a dental check.
if they haven't already had it, they need to let go. They see the dentist sees something like that.
They can't
There is
travel.
time
Oh, there's time to do it, yeah.
to have that treated so they can travel.
Totally. If that was occurring in someone's mouth right now, they'd be up to 2 instructions.
Yeah.
And they would be sutured by a colleague of theirs. They'd be on some antibiotics most likely, and they'd be healing very nicely, and they'd be ready for travel. Okay, tongue infections, avoidable. I put gruesome slides up because people see these things. That the gentleman on the right just wasn't brushing his tongue. That's a mixture of fungal and basically a dye job for the taste buds. And then this one here is cytomegalovirus, which a lot of people have inherently, and that's stress related as well. Thrush infections, definitely avoidable. All right, so again, I see them when people are stressed and run down, and essentially I've got some recommendations for some amphotericin, which is lozenges if you ever get that. These, by the way, live in your mouth all the time. They're in, and you pass them amongst each other, you know, intimately. And basically, if you get run down, they start to proliferate and cause problems. Lips, basically, we've got cold sores, which will happen. So I don't know whether people have from the GP, they can get pills you can take if you feel something itchy, can stop you straight away. And angular colitis is something that is stress or bad bite. And there's an ointment I'm going to recommend you just have, which is good for dermal lacerations and things like that. All right, so what am I recommending you pop into if you haven't already? Essentially, you've probably got a lot of these. So essentially, the 4 antibiotics I tend to utilize in my practice are these for different reasons.
The top 3.
Oh, you've got some, this is Remicin. Fantastic. Fantastic. A flagyl is, obviously, you can't drink alcohol with it, and it really makes you feel a bit nauseous, but it's good for giardia and also gastroenterology. We give it to patients if we're worried about microbes of an anaerobic type getting into the bloodstream. So we combine it with any of the others. All right, you'll hopefully have all those on board. Excellent. Chemicom is the ointment I was recommending. It's really good for if you've got something extra oral or actually on the rest of the body. It has an antifungal, it has an antimicrobial, and an anti-inflammatory. It's all around. And Fungalin is great if you have any oral fungal infections. Anesthetic, you can buy topical anesthetic at a pharmacy. That's not the brand, obviously, I think we have here, but it's about $40, $50 for a tube. It's very useful in a traumatic situation. At least you can give something. Diflam, I know a lot of teenagers who use that constantly because they get ulcers in the throat, and it's a good gargle or a lozenge, which will help numb you up if you've got something sore. And then betadine is really good. You can have both topical and also withdrawal. Toothpaste wise, anyone over 30, I recommend they use Sensodyne, not Sensodyne, but a sensitive toothpaste, because as we mature, our needs change. So, and that gives you a lot of calcium, potassium, minerals to repair and protect. That would sound like an advert. It's also good for gum recession and root surface. If you break a tooth, that will actually cover and block the nerve endings on the tooth. That's what it's designed for. High fluoride, I have quite a few clients on that who have saliva issues, medication that produces saliva issues, they mouth breathe, they're sleep apnea people, or have really sensitive teeth. And the combination works really well. So there we go, guys. That's a very quick overview. Thank you. Any questions?
So the standard preventative for any of those horrible things happening essentially be brush your teeth a couple of times a day, floss, etc., and then maybe salt water rinse or something just to get the other stuff.
And please, hopefully you've seen a dental person in the last 12, 18 months.
That's a requirement.
Yeah, because not everyone needs to see a dentist regularly. We're all different and we all have unique needs. And that's what going to a health professional is about, is working out what those needs are. That's all. By the way, my analogy for my clients for that is jumper leads. So if a car's broken down, you don't have jumper leads, gone. Well, anything else, guys? Sorry.
You said about the implant.
Oh, sorry.
Is there anything like that?
There was an interesting study came out a few years ago. This floss has changed its componentry. It's taken Teflon out as one of their ecological aspects for Colgate and other companies. So Teflon used to let things glide, especially around implants. If you have normal floss now, it will tear and shred, and it can get wound around it. And there was a spike in infections around implants in the US about 2 years ago, and they're trying to work out why. So
This is on someone's forearm, okay? And let's imagine that the wound edges are kind of trying to drive in a little bit, like I was talking about. What we want to do is we want to turn it over a little bit, put it on in the middle. You can see the blue bar that goes down into a blue arrow, okay? And then squeeze the trigger. And it's that easy, you know. And basically with the next one, again, really trying to roll it out just that little bit there, so that those edges do that as opposed to doing that. Okay, because what we don't want is to put up with this for a week, you take them out, then all of a sudden the wound falls apart. Okay.
Ultimately, size each time.
Oh no, not necessarily. Kind of good question. So basically, I'm just looking for the side that looks as though it's rolling in a little bit, and then I'm putting the arrow on it and just a gentle squeeze. Okay. So if everyone has a go.